My name is Joel Williams. I'm an orthopedic surgeon in Chicago. I split my time between Midwest Orthopedics at Rush and Stroger Cook County Hospital. I've been in practice about 10 years, and prior to starting my practice, I did 2 fellowships to really focus on all facets of hip problems and treatment options. By that, I mean this session tonight is focused on one aspect of hip preservation, a diagnosis called hip dysplasia, and the gold standard surgery for many patients, which is called a periacetabular osteotomy or a PAO. So preservation is one component to my practice. I also do hip replacements and spend a large amount of time fixing injuries or fractures for people that have had leg fractures, but especially fractures that are in or around the hip. I've been in practice about 10 years, and I'm thankfully joined tonight by Megan Ferguson. She is a former bilateral PAO patient. She also underwent femoral osteotomy on one side, and the added bonus, on top of being an awesome person, she's a physical therapist, so she can add her perspective as a former patient and as a physical therapist who really likes taking care of patients that fall into this demographic that have some sort of hip issue and are not an ideal candidate for replacement. And Megan does wonders in getting people ready for surgery or recovered after an operation like a PAO. First question is, what is hip dysplasia? I get this one a lot. Some people have heard about it in the newborn baby context. Some people have heard about it in the context of their dog or some other, four-legged animal that has dysplasia. And really, it's an umbrella term that encompasses many different specific sort of sub-entities that really just refer to a structural abnormality of the hip socket. And the medical term for the hip socket is the acetabulum. And that's what dysplasia is in a nutshell. It means that at some point during development, or I'd say less commonly when someone is born, there's a hip socket abnormality. We call those abnormalities hip dysplasia. Another common question is, how is it diagnosed? And I'd say the typical series of events is that somebody has pain. And that pain most commonly is in the groin, but it can be in the buttock, it can be sort of where your cell phone lives in your pocket, it can be in your back pocket, somewhere in that part of your body that prompts some sort of concern. And I'd say the most common stop when somebody's concerned is to an urgent care, primary care doctor, pediatrician, or somebody that is easily accessible. Sometimes it is properly diagnosed right then and there with an x-ray. Many times it is not. And usually the road involves a couple stops that could be a chiropractor, physical therapist, a sports medicine physician, somebody that does hip replacements only, and it can be a very long, bumpy road. Ultimately, ideally, somebody like this finds their way to my office or somebody's office that's experienced with hip dysplasia and PAO surgery. And then once somebody's here, we do start with x-rays, then we'll often follow that up right away with a CT scan or CAT scan, MRI, sometimes injections to complete the diagnostic workup. And then we talk about treatment options. And it really depends on the details that we find in those diagnostic tests. So what are the treatment options? That's the big picture question that people often come in. For somebody that has symptomatic hip dysplasia, does not have arthritis, the gold standard treatment recommendation is a PAO surgery, and that stands for periacetabular osteotomy. To make things simpler, we often use the abbreviation PAO, but that's not a universal recommendation. So the ideal candidate is somebody that does not yet have any arthritis or a minimal amount of arthritis. They're having symptoms. So in other words, if somebody incidentally shows up in my office and they're incidentally diagnosed with dysplasia, but they don't have any symptoms, I'm not recommending an operation whatsoever. If somebody shows up in the office and they have hip dysplasia on our diagnostic workup, but they already have some amount of arthritis, then usually our conversation's headed towards replacement, unless they have a very small amount of arthritis and or they're very young and they're not a good fit for a hip replacement. Non-operative treatment is in the conversation for virtually every patient. Dysplasia and dysplasia leading to arthritis is a debilitating condition. It can hurt a lot. It can erode your quality of life. It can be a major problem. At the other end of the spectrum, I meet plenty of patients that are very early in the process, or maybe they just don't have severe symptoms. So for somebody that's not having daily symptoms, their quality of life's not suffering, they can find a way to modify their activities and get stronger through physical therapy regimens. Non-operative treatment makes a lot of sense in the right context. And that's part of the conversation that I have with everybody that's in the office wanting to know about how to treat their hip dysplasia. Okay, she's on.
I figured it out. I needed to get on my phone. It was a lot easier. So
I know. I had the same realization at about 4 p.m. I was trying to get things set up on my laptop, and then I realized this is way more painful than doing it on the phone. So
that it
it's been a
is.
learning experience. We'll know better for next time. So this is Megan, who I was just mentioning. She's a patient that I've had the privilege of getting, being able to take care of. We've been through bilateral PAOs, femoral osteotomy, hardware removals. I think both of your PAOs were preceded by hip scopes, if I remember correctly, which is sort of where I left off. You know, what are the treatment options for dysplasia? We talked about PAO, hip replacement for those patients that show up that are already arthritic. And a common conversation related to this is, can we just do a scope, or can we do hip arthroscopy? And those terms are synonymous to treat the dysplasia. And I think the short answer to that, the gold standard is PAO surgery. Hip arthroscopy has grown like wildfire all over the world, especially in the United States, and people are trying to find the patients that truly benefit from it. There is definitely a role for patients with dysplasia that are getting a PAO to try to improve the outcome by doing a scope, either right during the PAO surgery, or in Megan's case, like a week or two beforehand with one of my partners that does relatively high volume hip arthroscopy. The data at this point is evolving. You know, there are several good publications that have come out within the last 5 to 10 years that show in broad strokes, or I guess in the big picture, when we look at big groups of people, there doesn't seem to be a major difference in the patients that get a scope versus the patients that get a PAO alone. So in other words, PAO alone versus PAO plus scope seems to produce the same result, at least at 2 years. And that's a really key point. Like, these are outcomes which take several decades to develop. So the papers that are coming out that at this point don't show a difference, those patients are going to be tracked for many more years. And my prediction is that for some patients, there is a clear role to adding an arthroscopy or doing work inside the joint to improve the outcome. I don't think it's going to be everybody, but we're still learning who exactly is somebody that should have a PAO plus arthroscopy versus PAO alone. Megan, were you able to listen in on the beginning
Yes, I
portion?
did. Yeah, yep. I would add on to your so actually I did not have my first I didn't have a scope before my first one in
Okay.
2022. That was I didn't I think I was going to have a scope and then you said no, I'll just look at it and then it ended up not being really needing too much so you just kind of did what you needed to do when you were in there. But
That's right.
I would say that I've seen a lot more people that come in my office talk about more of the combo of getting an arthroscopy with a PAO than I used to when I first started treating PAO patients back in like probably 2020. So I think, like you said, the research is evolving. There used to be an article that a lot of people would pull up about how like you could have a possibility of getting a scope and kind of manage your PAO with a labral, with just a scope of maybe a labral fix. But I think we're finding out more that that's maybe, like you said, not so much the case, but we're it's a kind of a newer type of procedure, a newer surgery. I mean, where I come from, it's not super common to even talk about this in ortho offices. So I think that, as you said, research is evolving, and from a PT standpoint, the same thing is happening.
Yeah, I take each and every one of these situations on a case by case basis. And if I see an MRI where the labral tear looks obvious, it looks large, it looks beat up, I think that's a scenario where addressing that labral pathology is going to improve the outcome. If it doesn't look like that, let's say I'm not sure. Like, I look at the MRI, I scrutinize it, and it's equivalent, and I think it's a coin toss as to whether or not there's actually a labral tear. That's one where I don't feel so strongly that doing anything inside the joint is going to change the outcome. Arthroscopy is one way to deal with labral pathology or things in the joint, and the other option is what you just described, Megan, which is during the PAO, I can open the hip capsule and look at the labrum from top down. So for patients that don't have an obvious horrendous labral tear pre-op, that's another option, is we can do it during the PAO.
I think too, like maybe backing off of that, like since we're talking about kind of liberal PO, maybe we talk about like why we talk about some of the angles when we talk about like imaging. So X-ray, CT scan, MRI. You know, we all love to have all of them, but they're important, right? So, and then what kind of the big angles and what they mean, because there's a lot of debate, I feel like, in the mild hip dysplasia category, because we've even had this conversation about like what do you do in that category.
Yes, that's a great point. So, and it's really hard not to get hung up on the exact numbers that come out when I make a coverage assessment. And by that, I mean I get an x-ray and there's sort of a standardized, it's actually not even standardized across the country. There are a couple different ways to make these measurements. That's a source of variability. If I make the same measurements on the same x-ray, but really what I'm getting at is, rather than focusing on the exact specific number, put all the numbers sort of together, and we look at things like the lateral center edge angle, the S-tabular index, the the tonus angle, the anterior center edge angle, the anterior wall index, the posterior wall index, Shenton's. There's a ton. Like we could talk for the next hour just on these described radiographic lines and normal ranges and abnormal ranges. But really, all those things get compiled together into one of three. That's the imaging component of the analysis. So I'm listening to patients talk and describe their symptoms. I'm examining the patients. I'm having them get up and walk. And then I look at the imaging. And I put all those things together into a diagnosis. And usually, or I guess in this context, we're talking about the diagnosis of hip instability, which is a little bit of a controversial term. It's not synonymous with hip dysplasia, but a lot of times they're used interchangeably. So you can have hip instability from a structural abnormality, like on the socket side, like we've been talking about. You could also have hip instability from a dysplasia, if you will, of the femur or the thigh bone, or both. And then also some people have normal or really close to normal structural measurements, but they're just super, super flexible. So somebody with highly elastic connective tissues can have symptoms of hip instability, even with normal or close to normal measurements. So, the lateral center edging has been used, and that's been the workhorse historically to establish the diagnosis of dysplasia, and then once the diagnosis is established, put people into a category. And the categories are mild, moderate, and severe. The initial description from way back in 1939 also included a subset of patients that were in the mild category called borderline dysplasia. And that term borderline has been widened over the years. So it used to be 20 to 25 meant borderline dysplasia. 20 to 15 meant mild, or mild really meant 15 to 25. The upper range of part of that range was borderline. So people like to get really hung up on, is my dysplasia borderline? Is it mild? Is it moderate? Is it severe? And that's, I think, a really interesting point for academics. But the reality is, if you have hip instability, your odds of getting better with a hip arthroscopy alone are small. They're not zero. There are plenty of people that have had a good result with treating mild dysplasia or borderline dysplasia with hip arthroscopy. But again, it's an evolving thing. We don't have good long-term follow-up studies on it, and we have a good procedure, which is the PAO, for people that have symptomatic hip instability and don't have arthritis.
Yeah, I think we get kind of hung up on the numbers as patients because they get put in front of us. But we also, like you say, and are kind of alluding to this whole time, is that we have to treat the patient what they're for, right? If they're symptomatic, then we have to consider that versus what you look like on a piece of paper. All right. So once you get it.
One other thing related. So dysplasia usually occurs while people are moving. So it's a dynamic problem, not a static. So when I get an x-ray of somebody, they're stationary, like they're static. And when people are describing their symptoms, it's rare that somebody says, it's only when I'm standing. It's usually like when I'm walking around at work or at school or doing XYZ. So we're making an assessment, an imaging assessment based off a static picture for a dynamic problem. And the hip, like all joints, are three-dimensional. And we're using, still the workhorse is two-dimensional radiographs. CT and MR are better imaging modalities for assessing three-dimensional things, but they're not validated. So I think if we had this same session in 10 years, rather than talking about lateral center edge angle on a plain radiograph, my hope is that our field will be evolved at that point enough to say we don't have a dynamic assessment, but we have at least a better three-dimensional understanding based on these advanced imaging modalities.
So yeah, when you showed me my CT scan the last time I had a PO, PFO with you, it definitely made a lot more sense to like see it in that version versus looking at an x-ray with these numbers that someone gave me. So once you kind of get going and things like that, why don't you talk about kind of like what the process of like you do during surgery?
I noticed you and Cassie put your minds together to ask, what music am I listening to?
We did, yes. We're super curious about this. Me and Cassie have a lot of questions sometimes about things, so.
All fair?
We're touching on this. So, for these, Cassie is also a patient. She had her PAO, her last one last week.
Yeah.
But fun story, Cassie and I kind of talked on Facebook one time about a setback that she had in PT after her first PAO, and then we ended up in the office at the exact same time for like follow-up appointments. So we've been kind of friends ever since. So like Cassie would tell you, she made a friend last Tuesday when she was in the hospital staying overnight. So find your friends in PAO groups, especially people that are close, like in the Chicagoland one. So, because it's kind of nice to have people that have been through it or going through it with you, or you just get stuck with them for the rest of your career. I have a bunch of patients that I still talk to that are yours and were mine. Yeah, I had a patient that was yours and that I treated it from PT that his mom texted me at his year follow-up after I'd seen him for 6 months that he was doing great and that he was fantastic. fantastic. So it's
Yeah.
cool stuff.
You're 100% right, and it's rare. I think that this is the only context where I'm recommending going to Facebook for credible information. The groups that you guys have formed is impressive. And, I think especially for the practical questions, when can I get back to work? When can I truly get rid of the crutches? When can I do X, Y, Z? Like, people that have been through it are more impactful and more knowledgeable than I am. I can get deep in the weeds and the science and the surgery and all the technical things, but the reality is people want to know when, like, I'm a human. I want to get back to real life. And like, when can I do these things? And the communities that have formed on Facebook are phenomenal in that regard. So music wise, I have a pretty broad taste in music, and let the nurse in the operating room or one of the reps for the implant companies that's in the operating room choose what we're going to listen to. When my go-to, my safe answer, which people make fun of me for because it's, the same answer usually, is Red Hot Chili Peppers. But Red Hot Chili Peppers radio is a good crowd pleaser. But
That's fair.
if somebody puts whatever on, usually I'm not saying change it.
I say,
Really
I have a couple of rep friends. What does the rep usually pick? You Red Hot Chili Peppers too, or he's something else?
It's all over. I mean,
Yeah.
I just let them, run with it. Yeah.
All right, nice.
Okay, so a PAO is a variable length of time. I'd say the fastest one is 2 hours. The longest one is the entire day. But the longest one that encompasses the entire day isn't just a PAO. It's a PAO plus I'm opening the joint and doing stuff in the joint, and I'm doing a femoral osteotomy, and that can be the bulk of the day. A PAO patient that has already had a hip arthroscopy ahead of where I'm not having to do anything in the joint is sort of fastest case scenario. So it's variable, but the incision is roughly 4 inches, maybe 5 inches long. It's hidden right in the groin crease. So when you put on a pair of shorts, it's generally concealed. Through that incision, I'm able to work between muscles and visualize this part of the pelvis. What conversation with Dr. Williams would be complete without pulling out these models?
Isn't that the truth?
So I'm able to see down like this. So the visualization is about where my hand is right here. So I can visualize this cut. I can visualize this cut in the front. This one down here is done with X-ray guidance in addition to this one in the back. So all of these cuts are done. It's in sort of sequential steps, and the exact sequence is variable. So the sequence is unimportant as long as they're done well, and meaning they can't be into the joint or too close to the joint. They can't be too far away. They have to be Goldilocks and just right. Once the cuts are done and this segment of bone becomes mobile, I can then reposition this fragment, so the hip socket or the acetabulum, and put it into a better spot. And then once it's in a better spot, then I put in screws, and the screws can be from front to back like this one. It can be top down. It can sometimes be in the pelvis right here, headed downwards behind the hip joint. So the number of screws, the position of the screws is too far in the weeds, I think, for this Q&A session. But essentially the steps are visualize what I need to see, perform the cuts, perform the correction, screw the correction in place so that it's stable and it's not going to move post-op. Once that's done, then it takes at least an hour to close everything back up. And then people wake up, they spend an hour or two in recovery. After surgery, the average length of stay is about 2 nights. Occasionally people will go home the day after surgery. Occasionally people will stay 3-4 nights. But I'd say 2 nights is a pretty consistent average. There's a CPM machine, which stands for continuous passive motion machine, which goes under the operative leg and just moves the leg. It's sort of like a cradle that moves the leg back and forth so the hip doesn't get stiff. And I don't want too much weight on the operative leg for about 6 weeks. And this is Megan's arena, so you can talk about this in a moment. But my recommendation is 30 pounds of force across the operative leg for 6 weeks. And then after 6 weeks, we move along to phase 2, where people can get off crutches. And that initial phase, the beginning of phase 2, getting off the crutches, is variable. I'd say the fastest that people can do it safely is about 2 weeks. The longest, for somebody that's had symptoms for a long time, they have weakness and a limp, the longest I've seen is probably 2 months. And then it's a progression with physical therapy. That's really when physical therapy becomes critical. For the first 6 weeks, I do think there's a benefit to some PT sessions, but the goals are just range of motion, and really they become essential once we're getting off crutches and starting to regain strength.
So yeah, there's a whole part of rehab, right, that probably for a whole different time, because that's just a bigger thing of, like, we've got the surgery done and then rehab looks different for everyone. I will say that the first thing you told me when I saw you the first time is that it takes 18 months, and I kind of laughed at you because I was like, oh, you don't know who you're dealing with. That's not a joke. Like, to be fully 100% doing what I wanted to do with that was going back to some sports or something, I was 18 months. you were correct. It's not meant to be easy, but it's definitely something that rehab is super, super important. And I think sometimes it is what makes or breaks a PAO and how much you feel of an outcome, right? Like nothing's ever perfect, but how much you put into something after surgery and how much you whether listen to your PT or do what you're supposed to or find a PT that you feel comfortable with, I definitely think will make or break how you feel that your hip did a certain amount after surgery. So I've seen different surgeon PAOs. I've seen yours. I prefer your protocol because it is a little tiny bit more conservative, but in a good way. And it gives me just enough guidance as a PT to know what I need to do, but enough for me to kind of even and flow with how people respond to different things. So I've had protocols where they like off crutches by like 4 weeks, they can start coming, like just kind of sometimes I feel like a little bit too fast considering what happened, but there's lots of different comments that we can make on physical therapy in that realm. So
Yeah, and it's individualized. I think as providers, we like to have protocols that say after XYZ surgery, this is my recovery. And there are definitely some people that heal faster than others. But I think what I've created, and it's not even my creation, what I've propagated from my mentor really is, years of trial and error and trying to shorten things and trying to lengthen things and finding a balance between being too aggressive and too conservative. And that works well for the majority of patients. Occasionally I can fine tune it a little bit. I think what we've created is a pretty good balance between too much and too little.
Say when I first had my first PO with you, I think I was like the 30 pounds for like 8 weeks instead of 6. So
Yeah, that changed. So initially it was 8 weeks and I've shortened it to 6 weeks. Of course, it's tempting to say 4 weeks, but when you think about the consequences of being too aggressive and not being healed enough to really increase the force across a healing osteotomy and having to redo an osteotomy because I was too aggressive, that's nauseating. Like the majority of people that are getting a PAO are young, healthy, they have good balance, they have good proprioception, they can handle crutches for 6 weeks. So I'm not at all likely to even shorten that beyond what we've got right now.
I think adding on to that just real quick that there's things that you can be doing in PT when you're allowed to go to PT that are not weight bearing things. And that doesn't mean just exercise. That means like range of motion, having someone work on your soft tissue because that just all got beat up and things like that. So there's lots of productive things that can happen in between that non-weight bearing phase or partial weight bearing phase.
All right, a few more questions that came in advance. I apologize right now that we're not going to have time to get to all the questions, but like I said before, we can pick up right where we left. So keep the questions coming. If I can't address it in this session, we'll make a list so that next time we do this again, we can pick up right where we left off. One question from Erin Swanson. Hi, Erin. I don't know if you're listening, but nice to see your name in the comments. Erin had PAOs in 2019. She said they're holding strong. How long does PAO surgery last? And that's for sure a variable answer, and it depends on the details. There are some patients that are in their 30s or 40s that are getting PAO where there's already a little bit of arthritis. That's going to be a different prediction than somebody who's in middle school or high school who's got a pristine looking cartilage surface in their joint. So for some patients, if they're, let's say, a mild dysplasia, they're early in their symptoms, they have great strength, they have typical dysplasia, not some of the less common variants, there's a very good chance a PAO will last them their entire life. For somebody that's in their 30s or 40s that has a touch of arthritis, then I'm very clear in telling those patients this is not going to last the rest of your life. This is a punt. At some point, in all likelihood, we're going to be talking about a hip replacement. When we look at the data that's been published to answer this specific question, there's a 20-year report and a 30-year report from Bern, Switzerland, where the procedure was first described. And to synthesize those two publications with the same group of people, the average length of benefit was about 25 years. So that lumped together lots of patients with different pathologies. So mild, moderate, severe dysplasia. It also included patients that had more arthritis than I think we're offering this procedure to today. It also included patients that had femoral problems, which is definitely a percentage of people. But in answering that question, it has to be very individualized, in my opinion. We'd have to check an x-ray, Erin, to answer your specific question. But if your PAOs are holding strong, in a way, it doesn't even really matter what the x-ray looks like. It may gauge my prediction about what's ahead. But for the most part, even if you're developing some arthritis in the x-ray, if your symptoms don't warrant a hip replacement, we're going to continue holding strong. I got a question from Jill Carta. Hi, Jill. How common is it for people with hip dysplasia to have back problems, especially SI joint problems? And I wish I had a number. It is, I wouldn't say 50%, but it's a high percentage. Like there's a large percentage of patients that come in and they're pointing to the front of their hip and they're pointing to their buttock area, like low back, butt, low, and the belt type area. And dysplasia for sure can produce symptoms like that in and of itself. without anything wrong with the low back, anything wrong with the SI joint. That's how some patients with dysplasia show up in the office. That said, there are some patients that show up in the office that have a problem with their hip, like dysplasia, and they have a different, maybe related, maybe not problem in their low back or SI joint. That's part of my job when I meet somebody, is to tease out what percentage of their symptoms are from their hip versus non-hip and counsel them. And if there's something else that needs to be done, a workup, a test, a procedure to evaluate that and to look at their low back and bring in a colleague that has an expertise in SI joint pathology or low back or whatever it is, then that's what we do. Because obviously, if I treat a hip problem, but the major pain generator isn't their hip, it's from something else, they're not going to get better, or they're not going to be happy because I got rid of some of their pain, but not the bulk. I got a question from Rebecca Fox, which was, given the advancements in total hip replacement, what are the advantages to preserving the natural hip joints? Which is a great one, and that one comes up a lot. I think if hip replacements were a perfect operation, I perform hip replacements. It's one of my favorite operations that I do. But if they had a perfect track record with no complications, hip preservation surgery wouldn't exist. The fact is, complications are real with every operation, including hip replacements. Number one. Number two, a hip replacement is analogous to getting a new set of shoes or a new set of tires. If you use it enough, it'll wear out. The current lifespan, if you will, of a hip replacement that I tell patients is 20 to 25 years. And there are definitely factors that can lengthen or shorten that prediction. But the reality is, until I see papers showing this hip replacement, this group of patients that had hip replacements put in 50 years ago never needed a revision. I still think there's going to be a major role for hip preservation, because when you put hip replacements into young people, especially, you're setting them up for a series of revision hip replacements over the course of their life. I had a few different questions regarding complications from Sarah Seelove. Hi, Sarah. One of them actually included a reference from a 2008 publication, which is about 17 years old, regarding complications, specifically nerve complications. And there's a previous post, like within the last month, that listed some of the risks associated with PAO surgery. And some of those risks are standard for virtually all surgeries or all hip surgeries. Some of them are specific. There's variability. So if you talk to surgeons about what are your specific complications and what are their rates, I think that's a good way to assess it. And then a different way to think about it are, what are the published complications? And some of those are, I don't want to say minor, some of these are horrendous, and some of these are recoverable. The ones that I have personally encountered, and the first one, I don't know if you lump this under complication or how you categorize it, but taking hardware out is a question that comes up a lot. Some surgeons recommend doing it universally at a certain time, and I haven't ever done that because I feel like it's another surgery. With every operation, there's a chance of something going wrong, and unless somebody has symptoms which warrant a discussion about hardware removal, I don't recommend it universally. For patients that have a healed PAO and tenderness right where the screw heads are located, I think those are patients that benefit from hard removal. In my practice, roughly that means around 10%, maximum 20%, but probably somewhere between 10 and 20% of patients. I've had roughly 10 to 12 patients that had to go back to the operating room because of a wound healing issue. We cleaned things out, took cultures, and then in the vast majority healed after that one clean out. I've had 3 patients get converted to hip replacement surgery, which speaks to the previous, and I'm not saying everybody gets a PAO is never going to get a replacement. That's not my message at all. But I think when you choose the patients carefully, you do a good job during surgery, and you're clear with expectations that the rate of conversion to hip replacements should be low. Shouldn't be zero. It's never going to be zero. But I think that's going to be a moving target. And of course, that relates to what we were just talking about the prediction of somebody that's in their 30s or 40s versus an adolescent. 2 different animals. I've had 3 patients have reoperation for non-union, along with a stress fracture, which is under 1% roughly risk factor. I've had to remove some extra bone that's also around 1% or so in my series. And the nerve complications, that was one of the longer posts or longer questions that came in. Nerves, just to give a brief description of what a nerve is. A nerve is our brain's way of talking to our muscles. It's also our brain's way of talking to our skin or sensory receptors. So you can think of it like a telephone. Like a phone has a speaker and a microphone. And nerves send signals from our brain to our muscles. That's called a motor signal. And if you have a motor injury, if you have a nerve injury which affects the motor function, that can be catastrophic. Like not being able to straighten your knee out out or bend your knee or move your foot up and down is life-changing. The other type of nerve injury that you can have, sometimes in conjunction with, sometimes apart from, is a sensory nerve injury. So that's an injury where your skin isn't functioning properly. Like if you touch it, it produces pain. And just a light touch shouldn't produce pain for a nerve that's functioning properly. There is a sensory nerve near the incision for anterior hip replacements, near the incisions for hip arthroscopy, and near the incisions for PAO surgery called the lateral femoral cutaneous nerve. So that nerve controls, it doesn't have any motor function, so it's not connected to a muscle and powers our leg to make us move, but it does connect to a patch of skin, sort of where your cell phone lives in your front pocket. And that skin that is supplied by the lateral femoral cutaneous nerve is irritable in almost everybody that has one of those operations. Any scar on the front of the hip tends to be near that nerve, and the nerve responds differently in different people in different surgeries. So worst case scenario, somebody has what's called dysesthetic or hyperesthetic symptoms because of that nerve being irritated. And it is almost universal. If you look closely enough at my patients that have had a hip scope, that have had a hip replacement, that have had a PAO, get stretched. It's not like we're cutting the nerve in half, but just getting into the hip requires that nerve to be stretched, and it affects its function. Sometimes that functional impairment is temporary. Sometimes it comes right back and fully resolves. Sometimes when it doesn't resolve, then we have to talk about nerve injections or ablations or other things just to quiet the nerve down to make the symptoms improve. And, like I said, I think if you look closely, everybody has some element of cutaneous nerve dysfunction. For the vast majority of patients, it doesn't affect their recovery, doesn't affect their outcome in a meaningful way. I've not had any patients with a motor nerve injury. There are three big nerves that go past your hip joint that power the muscles of your thigh, your foot, and your ankle, and your leg that allow your leg to move. And thankfully, I think, it's a very rare complication and not something that I've personally encountered. It is definitely published in the literature, and I don't pretend to say that PAO is a risk-free procedure at all. Like compared to a hip replacement, the risk profile is worse in some ways and it's better in some. Think about the worst case scenario after hip replacement, which for many patients is an infection. That can be a life-altering, horrendous thing that results in many more surgeries and sometimes having to remove the hip joint permanently. Anything to add, Megan?
I mean, I'm a unicorn in this situation from a lateral-cutaneous nerve standpoint. I actually had a very large problem with it on my right after a PAO, but it was very strange because I knew what to expect because I had scopes. So I knew it would get numb, but I still have some nerve burning type situations, but I've learned to manage it. I have a friend because, PTs have friends that do injections, but he just injects it whenever I need to, and he basically just hydrodissects the scar tissue around the nerve. If he does it enough and well enough, it stays good for me for 9 months to a year if I'm lucky. So I just go have him do that versus I'd explored other options at Rush about ablations and stuff like that. Was hard with insurance because it's not really studied for that particular nerve very well and they don't like to do things for that, but it's not the end of the world. There's things to get around it. I mean, there's always, we talk about complications. I don't like that word because inevitably something's going to be different after surgery because we opened you up. It's just a matter of knowing what that is, if there is something small like that, and moving on and figuring out how to get it to feel better. It doesn't affect me. I feel it burning, but it doesn't change how I move or what I do or how I function. So,
Megan, you've taken care of plenty of patients that have had PAO, hip arthroscopy, hip replacement.
Yes.
You've been through hip preservation on both sides. In regards to the previous question about why not just do a hip replacement? How do you think the average PAO patient, you can include yourself in, this this answer if you want, but just what are the similarities, what are the differences long term? Because really that's what I think people want to know. It's not for sure a PAO is a rougher recovery than a hip replacement. I think I'd be lying if I told you different. But it's an investment, and when you see people at the other side of their recovery, that's what really keeps me motivated and keeps me offering this procedure. But what's been your experience being hands-on as physical therapist with patients in comparing PAO patients versus hip replacement patients?
Honestly, I spend a lot more time with PAO patients than I do hip replacement patients because they're usually off and running and saying, "Oh, I'm fine," pretty fast, just because that's them. But I feel like PAO patients, I've never had anyone say they regret getting one. I've had, we have moments during recovery because it's not an easy thing and there's challenges to it. But I would say that from a PAO standpoint, like the ones that I've had, I get messages all the time about how fantastic they're doing, or they're doing better than they thought they would long term. They're moving, they're getting back to the activities that they want to. Some still play sports, some run. By one patient I talked about that his mom texted me, he is on a farm, like doing all sorts of crazy cow herding stuff. I don't even know. And he had a PAO and a PFO, not a scope, I don't think. But yeah, so I think that from like in a long-term outcome, I would say that almost sometimes from what I've seen in my 5 years of really treating PAOs is that they do better long-term than the hip replacements do from like a pain standpoint. I think there's different challenges to both of them because you have a lot of times you have age as a factor in there, and age can change how we heal and stuff like that. But I think that most PA patients that I've had, even the ones that's been very challenging, because I've had all the way up from the limit. So I've had 40-year-old PA patient to, I think the youngest I've had is like 15. They've all said that it was worth it once you get through it. I'm an example of small arthritis. We had a very long conversation about what we should do. I kind of felt like I pushed her buttons on doing it because I knew long term it was a better option than either wait until you need a total hip, which was probably going to be pretty fast because I was already struggling pretty hard, or just get a total hip and then be afraid of what would happen the end of my life because people don't want to revise a total hip more than maybe once, if that. So
Right.
I could have ended up with a total hip needing a revision a second time and being 75. So I think
I
from
remember
my
Yeah, I
yeah.
remember that conversation well.
Yeah, I was, if it makes anyone feel better, I was not very happy with Dr. Williams when I saw him in March of 2024 when I left his office. And then I gave it some time, and then I emailed his PA, Jess, and I said, hey, I'd like to talk to Dr. Williams. And then we had a conversation about it, and it ended up being better because we only planned to look at the joint inside and maybe do a PFO. There was really no PAO on the table when we first started all that stuff, and then ended up with all three.
Yeah, I mean, it's yes, that your situation was unique for some reasons, but the common thing that was relevant for you is if you have dysplasia and a little bit of arthritis and you're in your 30s or 40s and you're a marginal, like you're not an ideal candidate for a PAO, but you're not an ideal candidate for a total hip. How do you decide? And I think the easiest way to conceptualize it is you're very likely to have two operations over the course, minimum of two operations over the course of your lifetime. You can choose between PAO and then later on primary hip, or primary hip now and then revision hip later. And that's as soon as you start thinking about it that way, then it helps become more clear. For some patients, they prefer option one, and for some patients, they prefer option two. And this is not a black or white thing. I think it's a matter of matching the option to, the specific patient demands.
And I think you do a great job of listening to your patients. Like, you had to deal with me as a PT and me poking your buttons about why not this, why not that, why'd you say this, what happened? Like, no, like, I don't, little hard-headed anyways, but also know a lot more than the average patient that you may have. So you never told me no, we couldn't talk. You never told me no, I'm not gonna listen to you. You took what I had to say for worth, and then if you disagreed, you explained why. So, and then we came to a decision. So we're doing good.
Yeah, look at us now. Facebook Live.
We're famous.
Again, please keep questions coming on the website, on Instagram, Facebook, website, whatever, and we'll do this again. I get a lot of similar questions, but a lot of unique questions, and I won't be able to hit every single question on a format like this, but I think it's helpful for just general information and frequently asked questions. Anything else to add before we wrap it up, Megan?
No, I mean, Dr. Williams has my contact information. You can easily find me on Facebook now. So if anyone has questions for me specifically too, please let me know. I'm not in Chicago, but I'm in Southwest Michigan. So I do get a decent amount of Dr. Williams patients kind of this way. And it's kind of nice to have a PT if you need one that is in similar shoes or have been in your shoes before. So
you've been invaluable in that regard. It's always a pleasure to see your name on my clinic schedule for the day. But
for you, not me. I don't want to be on your clinic schedule anymore.
I don't blame you. You're not alone. Have a good evening. Thank you, Megan.
Yeah, thank
you.
you.
Next one. I don't know when we'll do it exactly. Right now, it's December, maybe January, but probably more like February.
Sounds good. Bye.
Have a good night. Bye.
Thank you. Bye.